Purple Solutions to Fix Healthcare in America podcast. Each week, we explore bipartisan solutions to healthcare reform through discussions with leading experts from across the country. To learn more, go to purplesolutions.org and join us at our Healthcare Economics Summit on July 31st.
All right. So hello again, everybody. This is Dan Sem, Dean of the Batterman School of Business at Concordia University and Director of the Arts Think Tank as well. And this is our next installment of the podcast, Purple Solutions to Fixing Healthcare in America. I am here today with Dr. Michel Accad. Dr. Accad practices cardiology and internal medicine in San Francisco, offering individualized care in a free market setting. So his blog about healthcare and medicine is AlertandOriented.com, and he co-hosts Accad and Koa Report podcasts, both popular blogs and podcasts. And interestingly, he's a fan of Austrian economics. So for those of you that know Austrian economics, you've probably heard of Friedrich Hayek. Hayek is one of the fathers of economics, and he said something that is sometimes misinterpreted, but he did talk about the need for a safety net in healthcare. And I'm really curious what Dr. Accad thinks about that concept of safety net later on in our discussion. So Dr. Accad, thanks so much for speaking with me today and our listeners, and hopefully at our July 31st Healthcare Economics Summit on Purple Solutions to Healthcare Reform in America. And you are, as a practitioner, at the front lines of delivering healthcare in San Francisco, and you have some rather disruptive free market views of healthcare delivery. I know you think a lot about the economics of healthcare, and you probably have a lot of ideas that are going to challenge our listeners to rethink how we do healthcare in America. You share these views on your blog and podcast, and I really appreciate you sharing them with us today. And as I alluded to earlier, in our previous podcast, we had somebody speak on the concept of universal healthcare. And towards the end of our discussion, I'd love it if you could give your thoughts on that as well. But for now, let's get started with a rather big topic, healthcare insurance. And I've always felt personally that the way we do insurance in healthcare in America is really dysfunctional. Anybody who's gotten one of those giant surprise bills probably feels the same way. I also think healthcare insurance gets in the way of anything even closely resembling a market or a free market. But you're more of an expert and a practitioner at the front line. So can you share your thoughts on how and why healthcare insurance is an inherently flawed concept?
Yes, Dan, thank you. Thanks for having me. I'm delighted to be here and delighted to share my thoughts with you and the audience. You know, so health insurance is indeed, my view is that it's, as you said, inherently flawed. I think we need to recognize that there are two concepts, when you use the term health insurance, there are two concepts that are clearly distinct, clearly different from one another. But they're conflated, they're mingled in people's minds. One concept is the concept of health insurance as being a risk hedge, the same way you purchase life insurance or you purchase car insurance. You know, if something happens, then you know you've paid monthly premium for something, and then you have that insurance cover the costs. You know, to try to make you whole or less, you know,
Right.
less wounded than you were before the event.
So that's something you wouldn't
one
use very
idea.
often unless there was a crisis or something.
Correct. So something, you know, so it's a risk mitigation.
Right.
That's one view, and then the other view is really as a social benefit, sort of a social program to subsidize the sick. Right. It's money given to the sick or to the poor, and here again it's kind of murky, and we need to understand precisely what's going on. But the idea would be an income subsidy for people who cannot afford medical care to be able to afford medical care, and those two things are really quite distinct.
Right.
And the problem is that we don't have clarity, and we should examine, you know, each one of them separately. And I think each one of them has its own very significant problems. Let's take the first one.
Okay.
As a risk hedge, if you will.
Yeah.
So the the problem with insurance in general is that, and that's clear for other kinds of insurance, whether it's life insurance or auto insurance or whatever. There's always this problem of moral hazard. Where people, you don't want people to abuse it or to game the system, to pretend that there's a problem when they're not, and then get money when in fact there's no damage or to the car or something like that, or they were responsible for the damage to the car and whatnot. And insurance companies can try to mitigate that, and they are more or less successful at mitigating this issue, primarily because, let's say, if you take car insurance in general, the contention that the car is damaged, that there's a malfunction, is pretty objective. You can get an expert appraiser to come and take a look and decide, and say, yes, this is what's wrong with the car, and this is what needs to be done. And based on that, in a competitive market of a lot of mechanics around and so forth, the health insurance company can come up with some kind of reasonable calculus, to compute how much the premium should be based on, the expected event rates of cars breaking down and so forth. Sure. And then they can put some clauses in their policies about the behavior of the drivers and what kind of, how drivers should behave, in order to mitigate the chance of accidents or damage to the car and whatnot. Yeah. So you can more or less rationalize it, and you can have the competitive nature of the market take care of things, and that can work, reasonably well. So that's if you take that and try to make it an analogy for healthcare, you see that doesn't hold at all for many different reasons. An illness is not like a broken, human beings are not like machines that break down, and then you can bring the impartial third-party ascertainer to come and take a look and say, well, the diagnosis is this. It seems that way, but it's very treacherous. It's not that. That's not what a disease is. That's not what a diagnosis is. It seems to us that when you say a diagnosis, that means that you have a broken part in your body, when in fact, a diagnosis is philosophically much more complicated. We may not have the time to get into it, but there's a fair amount of, I wouldn't call it subjectivity, because it's not completely subjective, but a diagnosis is sort of a professional conceptual model that doctors use in order to understand how people are ill and so forth. But the bottom line is that it's not something that you can just go and show the proof to the insurance to the insurer, saying, this is exactly what the problem is, and therefore, the thing should be paid. That's one reason why it's not analogous to the car insurance, for example.
So is an example of that problem you're talking about the kind of confrontation that you sometimes have between a physician and the insurance company about what should be reimbursed? Is there both sides are dealing with that? Correct.
Because the insurance company cannot send an impartial third party to double check with the insurance person, whether the doctor is, because actually the process of making the diagnosis is what a doctor does, is medical care, right? Is itself. Unlike the mechanic who fixes the car, you can send a third party, an independent third party. He can examine objectively and say, well, okay, it's a broken whatever manifold, and so forth. The process of making a diagnosis is actually medical care. It can only be done by doctors who are going to be, the beneficiary of the insurance reimbursement. So the moral hazard here is inescapable in a way for the insurance company. But what happens then is that the insurance company sort of demands to change the nature of medicine and to make medicine seem more mechanical than it really is. And it forces the doctors to codify things, to create codes, but everybody's familiar with this sort of disaster. But ICD-10 codes and whatnot. So it changes the nature of what medicine is, and that's a big problem. So that's that. There's also the question of well, is a treatment medically necessary? Well, what does that mean, right? I mean, we're actually all are failing bodies, right? We're all at different levels of degeneration, and we're all going to die at some point, right? So when is something absolutely medically necessary or medically indicated or whatnot? These are very artificial notions that are not objective, right? And you can have, let's say I have back pain, okay? And you can have back pain. Is it medically necessary that I get an MRI? Well, maybe I can live with it. Maybe I can. Maybe it would get better if I did physical therapy. How are you going to force me to do physical therapy? What if I don't do physical therapy? What if I do physical therapy, but I still have, can you get into my mind to decide that I've done sufficient physical therapy to do this? So it's very, it's impossible to sort of objectively ration. I mean, because health insurance as a risk hedger has to ration, in a certain way, whatever is being done. And it's impossible to do. And even for things that seem a little bit more objective as a catastrophe, like having a heart attack or whatnot. Still, I mean, at that point, you have a heart attack, or let's say you have chest pain, you don't even know that it's a heart attack. You could have chest pain, you don't know, you go to the emergency room because you think you have a heart attack, and you may incur, and it may not be clear for the doctors whether you have a heart attack or not. You may spend 2 days in the hospital, and at the end of that, they may say you're fine. Okay, well, was that a health catastrophe or not? I mean, should that be paid or should that not be paid? I mean, right?
Sure.
So for all these reasons, to think about health insurance as a risk hedge, doesn't work, because health is essentially, it's the concept of health that is uninsurable. It's not.
Okay. Yeah. And I get that. Let me just ask you about one specific scenario before you move on to the other sort of view of health insurance. Because we talk a lot about, and in the book that I wrote recently about orphan drugs, rare diseases, and those are inherently need to be expensive because it costs so much to make a drug. And if there's only 50,000 people in the US that have this, and you're unlucky enough to be one of those 50,000, there's almost no way around the fact that the drug's going to be expensive. It just sort of has to be. Do you see any logic for people being able to buy insurance for that kind of thing? Because it's a rare thing that happens to you, and when it does, it's really expensive.
I'm not sure. I don't think that we can tell exactly how expensive that will be. There's a lot of assumptions that we make when we, estimate, or even when we think that the doctor, now clearly there's there's a smaller market, but at the same time the demand is going to be lower. So is the production of drugs is very complicated. You have many things that are non-market friendly, as far as I'm concerned, that go into this. One is patent laws. Number two is FDA regulations. Right. And so
both of those things sort of get in the way of free markets.
Get in the way of free markets. And so, yes, under the current non-free market, people with rare diseases are going to be harmed by, more so than people with common diseases.
Yeah.
But it's not a problem with the free market. It's a problem with the regulations and the patents and the subsidies and all the other things. Right. And the fact that many people get insurance, which drives the cost of everything on top of that. So, yeah, I'm not, I would say I reserve judgment on whether orphan drugs are necessarily going to be more expensive.
Sure. In part because there are things that currently hinder the free market anyways, like FDA regulations and patents. So what about your other sort of perspective on insurance, sort of social benefits?
Right. So that's actually historically, that's how health insurance came about. In the 19th century in Europe, you had the emergence of the welfare state in Germany. You had the Prussian Bismarck and his state wanted to compete with the church to try to win over the support of the people by then being the purveyor of these social benefits.
Right.
And so that's the idea, is that you subsidize, but then who do you subsidize? Do you subsidize the poor? You could do that, and some countries try to do it that way. But the problem is that there's a tight link between being sick and being poor, and you can't predict to what extent sickness will make you poor. I mean, that's something that's in everybody's mind these days, right? I mean, with the Obamacare, and it was, if you have, especially under the current conditions that are horrendous, if you get sick, you can all of a sudden become poor, and therefore you have to insure everybody, right? I mean, it's impossible to set the limit about who you're going to insure, because sickness by itself has economic consequences that can be very severe, and therefore you end up subsidizing everybody, which doesn't make sense, because the subsidy as a social benefit should be the rich subsidizing the poor, but now it's everybody subsidizing everybody else,
right?
Which actually means future generations subsidizing current generations. It means burdening the future on the present with that,
which I suppose is what at the extreme Bernie Sanders wanted, but even Joe Biden is talking about sort of universal, like everybody.
Right.
So
that's the logical.
Obviously, as a free market person, you're going to argue that wouldn't work. Could you sort of talk about why you think that's not going to work?
I mean, I think economically, there's no. I mean, the subsidy has to come from somebody who can afford it. You cannot create money out of thin air, which actually we do, but it's not the real where we have. I think these debts are unsustainable. I mean, all developed countries have unsustainable debts. There's going to be a day of reckoning.
Right.
Now, people who have pointed
I have a $10 billion note from Zimbabwe. Actually, a $10 trillion note.
Right. Now, people, the counter would be, listen, we've done this for 30, 40, 50 years, and nothing has happened. Well, I mean, perhaps, but it's I think one can argue that it's unsustainable. Plus, number two, it's there's a lot of an indebted nation. I mean, this massive debt, personal debt, government debt, everybody's indebted. It's really making creating a lot of unhappiness. So it's not a medical opinion at that point. Now we're deviating away from healthcare proper. I mean, it's more of a sort of a general philosophical question about how a society should function. But I think these massive debts across the board are extremely damaging culturally and for people's well-being and for the future of generations. On a simple justice standpoint, the question of social justice, I think, is very unjust to saddle people with extreme debts like this.
Yeah. So just simply, it's financially not sustainable. I think CMS is already spending $1 trillion a year, which includes Medicare, Medicaid. And if you just do the math, that's not extrapolatable.
Correct. And when you realize that, then I mean that universal health has no way. The problem of moral hazard remains. Meaning, everybody wants more health. Everybody wants, to. I mean, not everybody, but many people. There's a face value plausibility to the fact that if you get more tests or if you get more treatment, your health will improve, and therefore, if you provide this subsidy to everyone, for any reason, it can only balloon. It can only increase. And the only reason that these so-called universal healthcare plan have embedded in them some kind of mechanism to interfere with the decision-making of doctors so as to actually prevent this from happening. So they talk out of both sides of their mouth. On the one hand, they say we want universal healthcare. On the other side, they actually interfere with it as much as they can, and they eventually have to interfere with it by nationalizing the doctors and the hospitals so that they can really control the costs, so they can really have only one MRI per, however they ration thing and so forth, the way it's done in other countries, but no other countries, especially since the fall, except maybe North Korea right now, no other country has true universal healthcare without a competing private sector.
Yeah.
Right. And so yeah, it's unfeasible, and it would be a disaster. Frankly, I'm kind of optimistic. I don't think it's going to pass. I think it's really highly unlikely that, especially in our current situation, June 2020. I think that's going to be
especially, and I mean, politics is so kind of shallow. They don't go very deep into the discussions. I think when people, maybe perhaps young people, are attracted to universal healthcare and thinking there's no competing private sector, that's actually, like you just said, that's not what most countries do. Even David Reimer, who we had next week, who was an advocate for universal healthcare, wanted to have competing private providers for that. So,
Mhm.
but
Right.
oh, go ahead.
No, just but on that note, whenever there can be competing, but there's always a tension, and there's always, for example, if you look at the UK, they always the public system always shifts the blame onto the private. It's divisive. It's like, oh, those greedy private doctors, they should do their share, and so forth. But the debt is the private sector can alleviate the rationing aspect of things, right?
Yes.
Because it's a valve that allows people to get care when they wouldn't be able to get it in the public sector. But it does nothing to the cost aspect of things, to the ballooning deficits.
Yeah, then the market will control costs. So,
Right.
I don't know if we're getting off topic here, but you do direct primary care, don't you? So, can you were talking earlier about how universal healthcare is controlling what goes on at the front lines with the doctors and decision making. I mean, a case can be made, and I think you were starting to make it, that patients get better care if there isn't sort of universal healthcare. And your practice is sometimes relying on direct pay. Is that true? So
Yeah, no, I think it's definitely not. Of course, I'm biased. So if I say patients get better care in my practice, I would say they may not be getting better care with me, but if there were a lot of doctors competing with me on the same terms, patients would be getting better care because they'd have a choice of doctors they could see, and then they have a doctor who's not distracted by these other considerations. They're not in an inherent conflict of interest. If you get paid by the insurance company, as I mentioned earlier, you're inherently having to play their game in order to get paid, and that's at the detriment of the patient.
Yes.
So it's inherently conflicted to accept health insurance. And now I understand that there are practical ways nowadays in the system that we have where the majority of the care is paid for by third parties, and things because of that have become so expensive that there are certain specialties. There's hospital care that as of yet cannot be provided on a direct care basis and so forth. But what's happening is that you have movements at the margin, like the direct primary care movement or the outpatient surgery movement, the direct care that way, where people try to find little niches where we can do direct contracting for certain things and try to nibble from the edge and try to move things in that way. And then maybe try to convince patients directly, or perhaps their employers, that this is a better way, both in terms of quality of care and in terms of cost, a better way to go.
Yeah, I hope people are more aware of that. I'm wanting to sign up myself. It's for like $75 to $100 a month. You get 24/7 access to a doctor. That's incredible, and it's less than my copay and deductible. So
sure.
In terms of the go ahead.
No, I think that's exactly right. You have access to the doctor, and you have a doctor that is beholden to your interests, and really has to, depends on you being satisfied. Now, of course, the doctor has to remain a doctor and not just do whatever you, right? Not just please you and on a superficial basis, but do what's right for you, and not be distracted. Yeah.
So that's a good transition to my other big question, about medical licensure and how we do it in the U.S. And, most of the time what we need to see is a primary care physician or maybe some other healthcare provider. Can you talk a little bit about your view on how we do medical licensure in the U.S. and whether there are changes that could or should be made? So.
Yeah, I think medical licensing is a terrible idea. I don't think it's unique to the U.S. What's unique to the U.S. is that the history of medical licensing is relatively recent. It started about 100 years ago, and therefore it offers a stark contrast between the pre-licensing and the post-licensing, and you can study it sort of historically and sociologically a little bit better than in Western Europe. Where in Western Europe you had always licensings for centuries before, ever since the end of the Middle Ages, when the kings started to give licenses to the colleges of physicians and things like that, and so it's a little bit more murky. But in the U.S., you really had essentially a free market in healthcare in the 19th century up until the beginning of the 20th century, and of course the promoters of licensing would say, look, you had these snake oil salesmen, and it was terrible. But that's not true at all. If you look at it historically, now of course they were snake oil salesmen, but the snake oil salesman was not really. That's really a manifestation of scarcity, and the markets actually, if you look towards the end of the 19th century, they were going out of business. The snake oil salesmen were going out of business, and you have the major institutions that to this day we still think of as, the best of the best in healthcare in America were products of the free market, of the unlicensed medical market, meaning the Mayo Clinic, the Hopkins Hospital, all these major hospitals that, the Mayo brothers who founded, and their father had no license, no medical license. So that's just, you don't need the government to rubber stamp your competence. And medical licensing really is, again, it's a philosophical. It's based on a philosophical error. It's based on the idea, which I mentioned earlier, related to insurance, because it's a similar concept, that bodies are like mechanics and that doctors are like technicians. And therefore, medicine is really a matter of technical competency. And so you take a licensing exam, you prove that you have your technical competency, and the state allows you to practice. And the idea when licensing came about in the early 20th century was to put out of business all the other what we now call alternative medicines. And it turns out that they never were put out of business. In fact, they flourished even better, overseas. But what's happened is that the state has started to license just everybody. So you have state licensing of homeopath and acupuncturists and chiropractors and all this, and so it's deviated from its initial quote unquote social aim to make medical care more scientific and blah blah blah. And what it does, so there are lots of both medical and economic implications of licensing. One is the economic one is fairly well known. I mean, it was brought to the fore by Milton Friedman, who said, "Listen, this is just it's a guild. It's the doctors protecting themselves, protecting their guild for their own financial interests." And there clearly was a lot of that. If you look at it historically, the introduction of medical licensing was really the doctors being wanting to their income. It was so competitive that healthcare was so cheap in the U.S. Healthcare was extremely cheap, even in the days of the Mayo Clinic and the Hopkins. It's very very cheap, to the point that the Mayo Clinic could offer 30% of its care for free.
Yeah.
So the doctors didn't like that. They said, well, I don't want to go to school for 4, 5, 6 years and compete with these other guys. So let's form a guild. Let's ask the state to put these other guys out of business and privilege us. And that's when doctors became, started to become really actually wealthy. And at the expense of patients, of course. So there's an economic impact of medical licensing, but there's also a medical impact in terms of how we doctors think about medicine, because again, it parallels what I said about insurance. It makes medical more of a mechanical process, when in fact it's not what it is. The diagnosis and treatment and all that does not obey mechanical rules, so to speak.
So would you do away with licensure altogether, or is there some sort of how do I know that you are a competent doctor? I guess I'd like to know that you went to medical school and.
Yeah, you would know that. You would know that. So you would know that. I mean, that's why the U.S. Historical example is instructive, because before licensing was around, people could distinguish the Mayo Clinic. The Mayo Clinic were competing. The Mayo brothers were competing with a bunch of snake oil salesmen and whatnot, and the patients recognized that the Mayo brothers were actually good people. They were sincere. They meant to do the right thing. They were successful. They could provide care. They studied. They were at the cutting edge of science. They actually introduced a lot of scientific improvement in medical care in the U.S. So the market, the reputation is what does it. And the medical schools also, their own reputation would become, without licensing, the medical schools would have a vested interest in the quality of the graduates that they provide. Whereas nowadays with medical licensing, the medical schools really don't care all that much. They become it's more about how much research grants they get and all that stuff. I mean, that's what makes the reputation of a medical school has to do with its research mission, not so much with its ability to produce good doctors.
So in that kind of free market world that you're talking about, I could choose a doctor that went to Harvard or Stanford if those credentials meant a lot to me, or if they didn't, I could shop elsewhere. But you'd have some
right.
validation that this person is competent
Correct.
based on what they've learned.
Right.
So.
But, and medicine is a social practice. So doctors don't, you have to set up shop in general, or a hospital serves a community and a doctor serves a community. So the reputation is extremely important, and the word of mouth is extremely important. And you could have doctors come out of, Harvard or whatnot, that they may be very competent at a technical level, but they may be, they may be ill-intentioned, or they may be, for whatever reason. So, but medicine by its nature is a social endeavor. It serves the community. A doctor serves the people, around them, and hospitals do, and so forth. And so reputation becomes very important, and it's a natural way of sifting who's trustworthy and not trustworthy.
Sure, exactly. Yeah. Okay. Well, that's giving us something very much to think about. I know with COVID in telemedicine, the federal government has sort of lifted regulations that require you to practice only within your state, but you're talking about a disruption that's a couple levels beyond that.
Right. And then, it's funny because now all these restrictions are being lifted, and then you wonder what good were they doing in the first place? Right?
Yeah.
If they can be lifted at a time where it's, the situation is catastrophic and there's a lot of uncertainty, and we find that it's good to lift them, then why don't we keep them lifted all the time?
Yeah. I mean, on the drug development front, AstraZeneca is talking about having 300 million doses in October, whereas normally that process takes a year and a half. So that's another case where if you can and the government's willing to work with you, things can go a lot faster.
Exactly.
Or if the government gets out of the way, I think you would say.
Right, exactly.
So we talked about a lot. Is there anything else you want to sort of, any closing comments or thoughts, especially as people are going to be voting in November, and there's a lot people are thinking about in terms of healthcare, and I think that we're going to disrupt in one way or the other. Correct. What would you want to share with people?
So now we have to be mindful. I mean, we live in a system that is highly regulated, highly subsidized. There's a lot of intervention of governments at so many different levels, and it's been the case for decades and decades, 100 years, and it's made people very dependent on the system. Mm-hmm. And people who are quite vulnerable, or at a time when they're very vulnerable, when they're sick and so forth. So we have to be careful with the disruption, right, quote unquote, because you don't want to pull the rug out of, you don't want to create chaos to the extent that you can. So I think policy should be trying to remove the barriers as much as possible, and to allow private free market enterprises to come in and to try to compete with the regulated sector as much as possible, and allow that to happen. I think the subsidies have to, will remain and have to remain. Yeah. But I'm hoping that over time there will be a shift, that people will realize that even with the subsidies, that they're better off going to a market where they pay a little bit more directly. I would love to see, but that would have to be at state level. At state level, to have deregulation of hospital care. There's a lot of places where crony established hospital systems lean on the state governments to give them to prevent other entities from building hospitals, from building maybe. Sure. And there could be, now we think of the hospital as this mega thing that provides everything from A to Z, because that's what in many ways the law and the reimbursement require. You could have little specialty hospitals that take care of certain few things, right? That start to nibble at the edges, and allow those to spring up and happen, and emerge. So we'll see. I don't know. I'm not pessimistic. I'm not completely optimistic, because it's a very complicated. There's a lot of dependence on the system. We'll have to see, but I think we should be. The policy would be the people who understand and essentially start to remove little by little the laws and the regulations that interfere with the natural way of that people, doctors and patients and the public would otherwise interact with one another.
Yeah. And hopefully people will see that they may actually get better care that way. I think
Yeah, right.
many people have trouble visualizing that, but you're doing
correct.
it. So.
Yeah, I think I'm very the direct care movement is doing well, and I think the word is going around. I think that's very helpful. The outpatient surgery movement is doing very well with Keith Smith. I don't know if you know of him, or in Oklahoma. He's been a pioneer. He's done this for 20 years,
Yes.
but now he's gotten a lot of attention nationwide, and many other surgeons are duplicating what he's doing. So for elective outpatient surgery, and then that will essentially set the precedents on which to build the rest of the system.
Well, thanks, Dr. Accad, for sharing your thoughts with us today. Appreciate it very much, and maybe I can talk you into coming on July 31st.
I'd be delighted. Thank you very much, Dan.